Hi there, welcome back. I hope you managed to grab a quick break whilst we're offline. So my name is Luke Parry. I'm a project manager at Health Innovation Yorkshire and Humber. First of all, I just want to say thank you very much to everyone that presented this morning. Some really insightful insights, I suppose, into what's going on and what's coming. So I look forward to seeing that. So this next session, we're going to be looking at the digital supplier demonstration, and we've tried to group these into the following themes. So the operational integration, proactive case studies, case findings, and also the support for management and patient self-management. Joining us today, we've got Holly Health, KiActiv, Enrich My Care, Abtrace, Brave AI, and the Joy app. And first of all, we've got Holly Health.
Hello.
Do we have Grace with us?
Yes. Can you hear me okay?
Yes. Lovely. Thank you.
Perfect. And I think I can take over the slides from here. Is that right?
Yeah. I think if you just request permission. Cool.
Perfect. Got it. Hi, everyone. Good afternoon. I'm Grace Jimson, founder and CEO at Holly Health. And I'm going to talk today about tackling chronic condition challenges and lifestyle risk factors at scale using personalised digital health coaching. And this presentation is going to cover four main areas. So the current challenge of proactive prevention, a real-world deployment example from West Yorkshire, how our service fits with the neighbourhood health model, and a few kind of questions or thinking points that I'd like to put to yourselves in relation to what's coming next. And there will be time for questions when I finish the presentation, so do save up anything you'd like to ask. The reality is that we're facing rising rates of long-term conditions, especially cardiovascular disease, metabolic conditions, mobility challenges, and mental health issues. And a lot of that is driven by lifestyle risk factors. GP capacity is clearly under immense pressure. And while most patients want to build better habits, they often struggle on their own. Nationally and locally, a lack of proactive personalised support leads to avoidable hospitalisations and unsustainable costs. So what we need is low-cost, scalable, patient-centred support delivered further upstream and in the neighbourhood. So I'm going to show you a practical example from a deployment in West Yorkshire. So we launched Holly Health with modality AWC, which spans GP practices in Airedale, Wharfdale and Craven. We provided 12 months of free coaching access to patients, inviting them proactively via SMS messages from their GP. After the deployment, we collated datasets on the baseline health of the people that signed up, lifestyle challenges, weight, blood pressure, and then we looked at outcomes as well across these areas, as well as things like self-reported GP appointment data. So I'll show you the results in a moment, but first a little bit of background on the Holly Health service. So it's a holistic behaviour change app, hence the Holly name, and it covers major lifestyle risk factors and chronic conditions like hypertension, type 2 diabetes, and mental health challenges like anxiety. Patients are guided by our digital health, which is called Holly, and it's a bird, and it's designed by psychologists to feel friendly and compassionate. Each person is taken through a web-based wellbeing and lifestyle habits check, goal setting, and habit planning. When they log into the app, they receive friendly, personalised coaching nudges and reminders, optimised with AI, and lots of content to support them with infrastructure as well to achieve small changes consistently. We use over 40 validated behaviour change techniques, and the service has been consistently improved over the last 5 years. It's a Class 1 medical device backed by the NHS Innovation Accelerator, Innovate UK and SBRI, and to date we've supported over 70,000 members of the public across more than 200 NHS GP practices. And just to comment on the conversation just before this around AI approaches and how models are built, we have a chatbot, but we don't use AI in our chatbot, which some people are surprised about. We use really safe kind of rules, processes and button responses inside the chatbot. However, we do have a really exciting AI use case in Holly Health, which is the nudge system that provides coaching messages, motivational messages personalised to the individual through push notifications. conditions. And that was actually built over 18 months with people with multiple long-term conditions and many people with mental health challenges. So now that that model is built, and we did that with Loughborough University as well, we know that that's actually been built with our end users in mind, and we can see it's really having a nice impact. So happy to answer more questions on the AI at the end. Obviously, inclusivity is super important. So we've built inclusivity approaches into our ways of working. So we use multiple entry routes to get to the service, from SMS invitations, online digital triage, physical flyers, notices on practice screens in surgeries, social prescriber referrals, and things like webinars on patient Facebook groups. Sign up is easy on any device and can be completed in any language, and it takes place on web. And crucially, we've co-designed this with older adults and hundreds of people with multiple long-term conditions. We also provide a non-smartphone route involving printable habit trackers for those without ongoing digital access. In West Yorkshire, with the modality cohort, over 2,050 people signed up within the first year. And the average user age was 50, with many users in their 60s and 70s. The people that signed up weren't the worried well. The average user had 3 long-term conditions at sign up. Weight management was the top goal for 41% of people, and those tracking weight started with an average BMI of 33. Also, 39% of the users reported a diagnosis of anxiety and depression, so we saw a high prevalence of both mental and physical health challenges. Our baseline data highlighted significant needs. So 63% of the group were under the national exercise guidelines for cardiovascular exercise, and even worse for things like balance and strength. 32% of the population ate 1 or fewer portions of fruit or veg per day. 46% of the group slept under 6 hours per night and showed high exhaustion levels, and nearly half showed signs of high anxiety. This data shows us and our local neighbourhood partners exactly where the needs are in the local population, and it helps to design kind of service improvement, come up with new ideas of ways of working, and this is all right at the beginning of a deployment together. And then we assess the health outcomes using follow-up surveys. So the outcomes after 8 weeks were really encouraging here. For those that completed follow-up surveys and started with low to medium scores, we saw a 41% improvement in mental well-being scores and a 40% increase in moderate exercise. We also saw a 27% improvement in alcohol drinking frequency and also 21% increase in self-management abilities. In 6-month surveys, these trends were either maintained or slightly improved, and that follows the pattern that we typically see, where the first 8 weeks is where the biggest changes happen, and then after that it's about maintaining habits, gradually in improving the outcomes and increasing more behaviours over time. Users provided feedback that they feel supported even though it's a bot. And the general theme in feedback is the service helps people to get on top of their mental health and increase abilities in self-care, which leads to more self-management confidence and habit consistency, and then the health changes result after that. Perhaps most importantly for the primary care system, we saw a reduction in GP appointments for frequent attenders. So that's an estimated 5 fewer appointments per year per frequent attender. Additionally, 25% of respondents felt an improvement in their medical condition symptoms. And we've even had users report that they're no longer pre-diabetic since using the service. And the approach fits really neatly with the 3 shifts required for overall kind of government health improvement and NHS longevity. So to move from analogue to digital, sickness to prevention, and hospital to community. And whether it's after a diagnosis, during retirement, or as part of a routine health check, what we want to do is support people by providing the glue for behaviour change and self-management across a wide range of neighbourhood health services and providers. So all of the types of organisations on the screen right now are organisations that we're used to working with. And we believe that actually the best way of working is to try and involve all of these organisations in a geographical patch, so that you can really increase the word of mouth and the awareness of the service availability, and keep increasing kind of adoption and usage over time. From a commissioning perspective, Holly Health is typically funded by PCNs, PCN clusters, federations, local authorities, or integrated care systems, and the cost can be as low as 8p per person in the population. And just to conclude, before I open to questions, I want to leave everyone with a couple of questions and thinking points. So in Yorkshire and Humber, where hypertension, depression and type 2 diabetes are prevalent into the hundreds of thousands, or in some cases millions, what methods do we think should be in place to support self-management and habit change at scale? And in the context of rising multi-morbidity, with around 450,000 people in Yorkshire and Humber living with both mental and physical health conditions, what types of holistic support need to be baked into the neighbourhood health model? And finally, in the UK, the average return on investment from prevention activities is around £8 for every £1 spent, but under 2% of public spending goes on prevention. So does neighbourhood health and the shift towards more kind of community-based activities enable a chance to kind of change the trajectory of that? I'd love to hear people's thoughts. So I'm going to stop there. I think we've got a little bit of time for questions. So welcome anyone to either put something in chat or shout out or put your hand up. Can't see anything coming through so far. Stuart?
Yeah, hi Grace.
Hiya.
Interesting presentation. Hopefully you can hear me. Quite often when sort of proactive initiatives to improve these kind of things and act in a preventative nature coming from the nanny state's work, it can be very difficult to get traction. What do you think? Where do you think there's an opportunity to link in with other parts of local partnerships, things like sports clubs, wellbeing activities? There's been some initiatives where I live in Northampton around linking up health and wellbeing with local sports clubs in certain parts of society and demographics. Where do you think there's an opportunity to, create those partnerships to gamify and encourage better outcomes?
Yeah, really good question, and totally agree. There's a massive opportunity to work with kind of activity-oriented community services. So a couple of examples in South Yorkshire, we're just integrating Holly Health with some Sheffield exercise referral processes right now. So that's one way of integrating. And another thing in Sheffield is we're working directly with a community wellbeing services provider that delivers exercise classes in things like church halls. And we found that actually combining the human and digital is a really, really great way to get people that might not typically engage more engaged. So definitely want to do more of that. To do that on a kind of larger, more national scale, we've also got processes in place right now to set up with about 5 different active partnerships teams. So these are Sport England funded kind of movement related organisations that are promoting lots of different initiatives locally. So we think by working closely with those organisations, we can kind of get closer towards those sorts of activities. So completely agree. Obviously, there's a lot of work to do, and it's kind of trying to do the top down and bottoms up approach at the same time, and also trying to link those activities closer to primary care, because I think tying the health services and the community services together gives a really, really great opportunity for kind of neighbourhood health.
Amy, I think you've got a question.
Yeah, thank you. Thanks, Holly. It was really interesting. I was just wondering, might be a bit of a random one, but do you have any evidence that backs up kind of the success of the programme with the sort of grounding of the behavioural science, psychological side of it versus a tool that maybe gave the same information but wasn't quite working from the same point of view, if that makes sense?
Yeah, the best way to compare that would be with a really large scale randomized control trial where one intervention is education and the other is digital coaching. We haven't done that yet. However, we're currently going through the process with NIHR to unlock the ability to do a large scale deployment to investigate that. However, anecdotally, what we see and learn from the users, and we've done thousands of user interviews now over the last 5 years, the main thing is that people trying to make changes on their own generally really struggle to sustain the changes. So the education is there. People kind of know what they want to change and they know what they should be changing. It's the process that's really difficult. Weight loss is a great example. Most people that try to lose weight on their own without a sustainable approach are unable to kind of keep it going over the long term. So we see much more sustainable outcomes compared to kind of what people have achieved in the past. So that's kind of our data points at the moment.
That's great. Thank you, Grace. It was really insightful. If you've got any more questions for Grace, please pop them in the chat, and then we'll move on.
I can just see one or two coming through in the chat.
Sure. Are you okay to answer them on the chat? Is that okay?
Yeah, of course. Yeah,
that's great. Thank you. Tommy, are you there?
Yes, I am. So let me just quest control.
Yeah.
Perfect. So good afternoon now it is, and thanks for having me here. So I'm Tommy Parker and I'm the CEO of KiActiv, and we are focused on delivering digital rehabilitation and self-care at home. We have been doing this in the NHS for a long time, and I think what we're seeing is a really positive discussion around neighbourhood health that is both something that we can help deliver on the aims for, but also that we have a vision for how neighbourhood health will also act as a springboard for kind of wider transformation and improvement in access and outcomes in these types of services. So what I wanted to do first was to give you a kind of an introduction to what KiActiv is, what we've been doing, and how it impacts on the neighbourhood health agenda, before talking a bit about the work that we're doing locally in West Yorkshire as well. And as it says, what we have created at KiActiv is a digital technology that is designed to support self-care at home across a number of different health and care pathways. And we've taken a really patient-led approach to this, really focusing on empowering behaviour change that can be sustained in the long term. So within the context of rehabilitation, this is a slightly new model beyond kind of the time-limited, recovery interventions that have typically been part of healthcare. And being able to take this forward has been, quite a long journey. We did our first feasibility study in 2014, but were in December recommended by NICE as a digital cardiac rehabilitation tool. And this builds on the support that we've been delivering around proactive self-care, delivering significant patient and system benefits across multiple different pathways. And the way in which KiActiv works with the NHS is as a partner to provide a turnkey solution that increases capacity, provides a really appealing offer to patients that helps to increase their access to care, and doing so at a really affordable price. We've been able to demonstrate independent clinical evidence that shows significant reductions in hospital readmissions, A&E visits, and improves healthcare utilisation more broadly to deliver the savings that we all need and want. And the way in which we've looked at this kind of use of technology is that, we wanted to make sure, obviously, it's easy to use from an accessibility point of view. It's personalized, that we can cater for the variety of different situations that people find themselves in across different rehabilitation pathways, including the kind of multi-morbidity aspect of it too. But a key thing for us is that it's not just about the rehabilitation at the start, but actually that we can create this seamless transition from kind of treatment to long-term lifestyle change and enable people to be in a position to live their best lives for longer. And all of that really aligns with both the neighbourhood health goals, but also the 3 shifts. You can hopefully see that by bringing kind of digital cardiac rehab into kind of services, that we're able to make that shift from hospital to community, obviously secondary prevention within the rehabilitation processes, and harnessing digital in a way that can be really positive and effective. And this may be kind of known to everybody, but I wanted to give the context of what the current challenges are within rehabilitation and where the current model is kind of failing the patients and the system. And the key thing is that the majority of people who are eligible for rehabilitation are either unwilling or unable to take part. There's a number of different kind of well-evidenced barriers that exist. And it's, obviously to the detriment, because it's such a widely recognized positive influence on their health outcomes. And it's why, in cardiac rehabilitation, for example, the long-term plan goals are to achieve 85% uptake. And these systemic access barriers, such as the time it takes out of people's lives, the travel that's involved in getting to face-to-face facilities, some of the costs, some of the psychological aspects around, people's fear or cultural aspects that do prevent them from engaging in exercise in its traditional form. And people also find that kind of exercise is very prescriptive. It's about being told kind of what to do and when, and, having to fit in with that, which doesn't really account for the variation of people's lives, but also doesn't give them the foundation for sustained lifestyle change that is really needed in long-term conditions. And what we're finding as well, just based on all of the data, this is creating a rising gap in kind of disparity. So, the inequalities aspect of rehabilitation is quite significant, with the people who really need it the most, typically being the ones with the biggest barriers. And to overcome kind of the current situation around the barriers to exercise, we've really taken an approach that enables people to rethink what that means for them, and to also harness their everyday movement as the medicine in terms of rehabilitation. So it's really about harnessing the dose of all movement, but in a very personal context to the individual. And we've seen that this has a number of different benefits. The first is that it does massively increase the opportunity people have to change. The old model of rehabilitation is kind of typically 1 to 2 hours of exercise per week for 8 or 12 weeks. But when we start to think about how we can get people to optimize their dose of movement across their whole lifestyle, you're looking at suddenly their whole waking week, all 112 waking hours. And by increasing the possible dose, you're also able to have a much bigger impact. And we've seen that in our randomized control trials and other real world implementations as well. The physical activity in all of its intensities, delivered in this way, can massively improve cardiorespiratory fitness and all of the benefits that flow from that within these clinical pathways. It's also been easy for people to understand, has reduced kind of barriers to age or mobility and some of the fear around exercise, with the one-to-one support we provide, enabling people to really have the confidence to do what they need to do, but in their own home environment. We're not using kind of traditional exercise videos or kind of exercise prescription. And part of the reason of that is that it can increase some of that clinical injury risk. And so from a patient safety point of view, really focusing on a more personalized view of their physical activity and their behavior has been incredibly important. And sitting behind all of this is a huge amount of data that not only provides us general insight into the population, but is really valuable for being able to show what that impact is at the system level. So being able to translate some of the improvements in physical activity, quality of life, things like that, into something very much more meaningful for system metrics. And this is just a snapshot of where we've been working in terms of our evidence. You can see from the right-hand side that we, have delivered quite significant outcomes, and this has been published across a number of peer-reviewed journals. Some of the key outcomes in the rehabilitation space for us are kind of improving the adherence to physical activity guidelines within rehab programs, delivering a 2x greater fitness improvement than usual care, and also being able to deliver significant reductions in 30-day and 90-day readmissions for heart failure. And this is important kind of backdrop into what we look at in terms of neighbourhood health, because obviously we've had to design the kind of new approach and the way in which we do it, evidence that. And I think now this gives us the foundation to look at how we can really impact on the neighbourhood health agenda. And when we think about neighbourhood health, we think about it in two ways. First, we think about it in terms of what we can do to help achieve the neighbourhood health agenda right now, which is by establishing an easier access to supported self-care at home, being able to move more services into the community, but it's also adding that kind of additional digital capacity on top of current services, where part of the challenge in rehabilitation is that there is limited access. It's also reducing some of those physical and psychological barriers to exercise. So we're really focused on the patient experience here and their access to care that's going to benefit them. And this includes overcoming some of those travel and cost hurdles that do impact the people kind of least fortunate the most. And crucially, this kind of one-to-one guided mentor support really facilitates the self-management, caters to multimorbidity, and enables people to have a long-term view of what their health will look like. And so these are their areas that, from a neighbourhood health perspective, we can deliver on right now. But I think just as crucial as what we can do right now is actually, what does the shift for neighbourhood health create as a foundation for doing even more? And when we look at rehabilitation, we look at rehabilitation in its kind of current scenario, where it's offered, because of its limitations in capacity, to kind of the people who are in the worst situations. It's kind of a very acute way in which people are offered rehabilitation. But we see neighbourhood health as an opportunity to kind of reset that balance, to be honest, and have digital rehabilitation as a neighbourhood asset, something that can be referred to or signposted to across a number of different places in the community, hopefully more upstream, so that it can be earlier on in someone's journey, but reinforcing this very patient-led approach that covers a number of different conditions that we know, by taking a patient-centered view, we will encounter. So then, just to kind of give you a brief perspective of what we've been doing in West Yorkshire, this is a quick overview of actually what the service looks like. So, I've been talking a lot about kind of everyday movement, but we have a multi-component way in which we deliver this, which includes providing everybody with a physical activity monitor to accurately capture their movement in all intensities across their waking day. Our patented method before displaying that back to people in the online dashboard, because no data is shown to people on the wearable or kind of within any of the kind of data transfer tools. And that's very purposeful, because we're really focused on intrinsic motivation for behavior change. We want people to be able to leave the technology at the door and still have learned all of those lessons that enable them to make better choices moving forwards, moving away from kind of the idea of needing those external influencers to make people make those choices. And providing that support, again, has been a crucial aspect for motivation, but also the accessibility, which is, I think, crucial. And so this brings me to what we've been doing in West Yorkshire. And this has been kind of a programme that's facilitated through the Health and Growth Accelerator, but is enabling us to work with 9 different providers across West Yorkshire, across a number of different clinical pathways. And it highlights how we can be flexible to specific local need and the value that digital rehabilitation can bring in terms of the opportunities for kind of changing the way in which care is delivered and the benefit that patients can access. And this kind of main attention I would draw you to on the left-hand side is the areas in which this is being offered to people. So whether it's to support waiting lists, to augment current services as a digital alternative or as a step-down referral, these are the important ways that supported self-care can be embedded within services. And just quickly, from a kind of a snapshot of where we're working across West Yorkshire, you can see the variety of different conditions that can be worked with. So thank you for your time. I hope that's been insightful, and I welcome any questions that you might have.
What's been one of your biggest challenges, Tommy, especially as you're implementing into lots of different areas within the district?
Yeah, I think from an implementation point of view, the co-design and kind of collaboration process at the start is really important. So we were fortunate with the support of the ICB and really strong engagement from the providers that we were able to get kind of into the weeds of what the problems were and actually how that varied across the different providers and across the different pathways. And it highlighted to us that there is, even within kind of the region, a huge amount of variation and different offers available in different parts of the patch. So I think without kind of having that strong engagement and collaboration at the start, you risk not really understanding kind of where it should fit in with the pathway. And there's always a really kind of strong risk with that in terms of rehabilitation. Because you don't want to repeat the pitfalls and the barriers that have led us into this situation. There's a risk easily that you could just digitize what's come before and kind of retain a lot of the barriers to exercise or the things that kind of stop people engaging in rehabilitation, which, we do have to deal with the kind of the behavioral underpinnings from that individual's perspective as well.
Cool, thank you. And we've got one question in the chat as well. I'm not sure if you can see that one.
Yeah, let me bring that one up. So I can't see that question.
So do individuals and places not have do some individuals and places not have reliable network connectivity? So whether that's broadband or mobile to support the digital services in home or communities, and how do you overcome that?
Yeah, I think the digital access and also more importantly, the digital confidence is something that has to be well thought out. What we tend to find is that kind of digital access is more prevalent than it isn't, and it's more the confidence issue that people have that needs to be addressed, and that's part of our kind of service design. By having that one-to-one guided support from the mentor means that we can kind of effectively hold people's hand through the journey. So every time they're introduced to a new bit of the technology, we can help them to do the basics. And so that might be that somebody has never logged into an online platform before, and that we can spend the time on the phone helping them to become comfortable with that situation. But in those examples of where it may be less prevalent, what we tend to do is during the onboarding phase work with them to understand their network, whether that's family or friends, what community they're in, and what available assets there are and support there is in the community. Because we've designed our service to not need kind of constant interaction. People can get away with, uploading their data kind of a couple of times a week rather than every day, maybe interacting with their data in the online platform once a week rather than more frequently. So that kind of cadence can cater to the availability of the technology and the digital access that they have.
Thank you. Are you okay to keep an eye out on some more questions in the chat if anything else comes up?
Yeah, absolutely.
Perfect. Thank you, Tommy.
Thanks.
So just moving on next to Enrich My Care from Saran. Are you around? Are you available? Saran, are you here? No, looks like I've been stood up. Do we have Dr. Ignat online?
Yeah, I'm here. I'm just thinking it might be 10 minutes earlier in the agenda, so maybe that's why Saran is not there. But I am certainly here.
Are you okay to jump in?
Yeah, that's not a problem.
Perfect. Thank you.
Make sure my camera is on. Excellent. So, first of all, thank you very much for the invitation. I know I'm a little bit of an outsider coming from the southwest, all the way up to the northeast. So it's lovely to join you here this afternoon. So my name is Ignat. I'm the CEO at Behring. I'm a medical doctor by training, so I trained a long time ago now. And before AI was cool, I did a PhD in machine learning. So again, that was even before the medical degree. And I've always had the ambition to join the two things together. So essentially, how can I use machine learning together with clinical information to make clinical decisions better, to improve patients' outcomes, to improve outcomes in the community. So that was the genesis for my business, Bearing, and Brave AI is one of the products that Bearing has developed over the last 10 years. We, in fact, started working with this idea of a neighborhood, again, about 10 years ago in Somerset. So we were thinking for a long time about what does it mean to be in a neighborhood team? What does it mean to use data? And that was the genesis for Brave. So for those of you who haven't come across Brave before, so Brave is a medical device. So it's a software as a medical device that enables predictive, proactive care. And that's very important. The regulation element is very important. I think the fact that AI is being introduced into the healthcare setting implies a certain degree of certain degree of regulation is required. And in fact, when it comes to proactive care tools, in terms of predictive proactive care tools, there are only two in the UK that are UKCA marked. And that's the EFI, which I'm sure you've come across before, and also Brave. So our evidence and our, I guess, work over the last decade means that Brave can address this question of, if I'm a clinician, I have a community of 50,000 people, who are the 5 people that my team should be working with this week? And that's crucial, because I think historically that patient selection was very much heterogeneous. So they're either referred through secondary care, there are other services referring them. And oftentimes the care itself becomes much more reactive. So in response to some sort of crisis that a patient has experienced recently. So shifting that much more upstream becomes the idea of this predictive proactive care. So can we predict which patients could benefit from a proactive intervention? Could we actively reach out to them? And that's the challenge that Brave is trying to address. I've highlighted it in this proactive care pathway diagram from NHS England, which I'm sure looks very much familiar to everyone. So again, it starts with this age-old question of who is the right person. I listened to a couple of talks this morning, and I think there were challenges also being recognized that oftentimes people can be quite, whether there are other services that are already involved, perhaps their health journey is a little bit more downstream than proactive care could be benefit where compared to proactive care. So again, finding that right person in a large community is the challenge. So identifying the right patient so that we can deliver the holistic assessment, personalized care and support plan, coordinate an MDT intervention, and then finally plan for continuity of care. So I think the element here that's quite surprising, I think, is this delivery of continuity of care. So it's not just about ensuring that the care itself is continuous, but it's also supporting and trying to identify early which patients could benefit from additional continuity. So these are the elements where Brave comes in and slots into the clinical pathway. And again, I think this talk is, I'm not going to dive into the sort of the technical thing of what Brave does. What I thought would be more useful is try and condense my kind of last decade of experience into some lessons that we've learned along the way, how we work with clinicians, how we'll work with citizens in our neighborhoods, and highlight both the challenges, but also some of the ways in which primary care networks and our primary care colleagues have worked to address them. So in terms of where Brave is, so this is the scale of the current live Brave sites. So we've been commissioned by NHS England across 8 integrated care boards, mostly in the southwest. We work with 47 primary care networks, and we cover 2 million monthly patients. I think it's very important, again, from a compliance perspective, that AI is regulated. So from the point of view of UKCA marked, so there are plenty of risk stratification tools, but as soon as a risk strat tool is being used to find a person and then phone that person up, that means that risk strat tool must be a medical device. So having that regulatory oversight is crucial. Ensuring that the software itself is built to the highest safety and profile is critical. So having this ISO 13485 standard is very very important. And finally, the DTAC compliance, again, ensuring that the other parameters like digital clinical safety, cybersecurity are aligned as well, are paramount. What we've also learned is that there's quite a few more bits of due diligence that need to happen, and importantly, is the digital clinical safety, because again, this has been my passion for the last several years. So in fact, we worked with our clinical safety officers in the Southwest together, and we've just been nominated for an HSJ award for digital clinical safety. So thinking about not just adopting a digital tool, but how can it be that it's adopted in a safe way, in an effective way, and actually using digital clinical safety as a tool to improve the operational efficiency of the clinical team, rather than it being seen as a bottleneck and in the governance process. So all of these things, we've worked very carefully with patients, with NHS England, with the ICBs, with the primary care networks over the last several years to refine, to template wherever possible, and to make it easy for local teams to adopt. The first bit of learning, I think, it resonated really wildly with me. So Brave is used across all of Cornwall at the minute, and I think Cornwall is one of the integrated neighbourhood pilots. And this was an independent evaluation from Future Care Capital, which looked at the Arbanecht integrated neighborhood team. And one of the members of the team rightfully said that, what is an INT after all? And this is a direct quote from them. So we had these, quite big meetings with lots of different professionals in the room, but it all seemed a bit nebulous. What is this all about? Where is this going to go? So I think the concept is interesting, but how it would be operationalized by individuals on the ground, that was the nebulous element. And we're seeing this across every other INT that we work over the last few years. What came out of this evaluation was really interesting, is that it seemed that whilst Brave is a case identification tool, it actually was used to define what an INT should be. And I think that was really unexpected to me. So the fact that this digital tool has an intended purpose in terms of how it's used clinically, but also the fact that it seems to provide the shared focus and structure to the team around itself, so that they can see what the plan could be, and they can work towards a specific shared agenda. So I thought this was quite interesting. I left a link to this document in the slide there. If you're interested, there's a really interesting interview as well, which just generally described the challenges about how do you actually form an INT so that you work effectively together. The second learning point is, again, from the regulatory side. It's quite fragmented. So there are certain areas which are very much up to date with the regulatory requirements. Others are not so much. And the biggest difference, I think, is we found so when we deployed to 8 different ICBs, we went through 8 different deployment processes and requirements. And that's, I think, difficult. If we're going to be thinking about neighborhood health and scalability, this adoption from the governance perspective should be a unified approach. There should be some sort of set of standards, which my understanding was that's what the DTAC is for. The reality was very different. So DTAC was very rarely seen as a requirement. And there were, in addition to DTAC, there were other things within each system that were required for a tool to be adopted into clinical practice. So this was, again, it was unexpected. It was quite challenging, and I think that's just the reality, that behind the scenes, there's once the tool is actually adopted and it's being used, that's just the tip of the iceberg. There's a huge element of governance that goes around in supporting anything from data sharing, consent, regulation, compliance. All of that stuff has to be looked after. One thing that I haven't mentioned is that so Brave was designed for primary care. So our hypothesis initially was that proactive care happens in the community, and by the time patients get into hospital, it's already too late. There's 4 or 5 years ago, if there was a crystal ball, perhaps primary care in the community is where the intervention should happen. And of course, from a clinical perspective, that's very challenging. How do you do more intervention with less financial resource? But practically, we see primary care being as the sort of the gateway to proactive care. And we work diligently with primary care and with patient participation groups in primary care to develop Brave for primary care. So it uses only primary care data. It learns what the sort of the good coding practices, the poor coding practices. It tries to correct for some of these, for some of the heterogeneous elements within various regions. So again, it's a very much a tool born and raised in primary care for the use by primary care teams. The final thing that I wanted to share is I think the sort of this line from Anna Karenina rings a bell. I think Leo Tolstoy opens it up in something along the lines of, every family is happy in its own is happy in the same way, but unhappy in its own unique way. Horrible paraphrasing, but I hope I can convey the point here. What we found is that every team is unique. So they have their own priorities, they have their own strengths, they have their own weaknesses. And for us, as part of this digital clinical safety, it was very important to recognize the strengths, to recognize the weaknesses, and make sure that Brave works within the context and within the framework of the team. The consequence of this means that the tool was very much bespoke to each individual INT, and that was the strength of it. So I think historically, especially risk strat tools, they've just sort of been dumped on a GP's desktop and off you go, do whatever you need to do. The reality is different. So we took a much more hands-on approach where we work with the INT. We define what the clinical safety case should look like given the different constraints. There's no point in Brave identifying 3,000 people if the team can only review 10 people. That's completely demoralizing. So we need to understand those parameters very early on so that the process becomes a joy, and teams can get that joy of working together again. As a consequence, there are a large number of use cases that have emerged from this. So frailty being the most popular use cases, so looking quite upstream into moderate frailty. Health inequality, so working with 20% most deprived, additional chronic conditions. We worked with Sir Professor Pereira Gray in Exeter to explore how Brave can be used to predict continuity of care and help teams triage patients who could benefit from additional continuity of care. Usage in a care home setting to prevent falls and A&E attendances. Polypharmacy, cardiovascular, so virtual, triaging people onto virtual wards for cardiovascular conditions, COPD. We work with the PCN in the Southwest, who are working with the university's mental health outreach team. And again, they're using Brave to identify students who could benefit from additional mental health support from the university. And as you can expect, that shifts the demand from primary care and then off to this existing resource, which is being used in an appropriate way. So again, this was quite unexpected, as we thought it was all about preventing an admission. But no, each team has their own wishes, how they wish to work with their population. They know their population best, and they see some they implement Brave in the way that would suit their needs as a community. The unifying factor in all of this is the process of how Brave is typically used. So it starts out usually with a care coordinator running, working with Brave on a regular basis. The regularity is very important because it's not an ad hoc tool. There needs to be a built-in momentum. So whether it's a weekly rhythm, bi-weekly, whatever it is, there's this regularity of triage, of identifying the right patients, the right number of patients, which are then handed over to the INT for a more in-depth review. There's a situation background assessment recommendations. So this information gathering from all of the stakeholders. So whether it's a care home, the care home contributes to the SBART assessment. If it's a community, so one of the PCNs is working with dementia patients, and they realize that actually the carers are such a huge part of that patient's well-being. So the carers become part of the MDT for this dementia frailty cohort. And again, that was I think it reflects of this general need to involve the broader range of contacts that are impacting every person's health journey. Once this information has been gathered, that shifts into then the patient moves into the active intervention. And this is where the links to local social support services are made. This is where an occupational therapist can go out into their home and do a comprehensive geriatric assessment, do a falls review, signpost people to additional services, etc. So again, very much personalized. But the process itself, as you can see, it's been standardized. The steps of the process have been standardized, and then a patient follows up through the whole pathway, all through discharge. And as a final thing, I just wanted to show you a couple of metrics and outcomes that the teams that have been using Brave for their proactive work have been able to measure. So this is a 3-year study which looks at proactive care for moderately and severely frail patients who are age, sex, and frailty matched to a cohort of Brave patients that were identified through Brave and were given this proactive intervention versus a standard of care for frailty within the community. So the pink line is the standard of care. So that's the control group. And the numbers on the y-axis measure the prevalence of hospital admissions, and the numbers on the x-axis measure time in months. So over time, the number of hospital admissions per person per month was increasing in the control group. In the Brave AI intervention group, we see that there's that initial plateau for about 18 months, and then after 18 months, the number of hospital admissions per month per person has started to reduce. And then, of course, at the end of the 3-year period, we can measure the difference. This answers a really interesting question. The first one, of course, is does this intervention work? Are the right patients being identified that leads to an improvement in their outcomes? But the second question, which is more interesting in my view, is how long does it take for the benefit to realize? Because every time you deliver proactive care, it's a leap of faith, because you're not going to realize those benefits tomorrow or in a week's time. There's a time horizon to those benefits. And the question is, how long is that time horizon? Is that time horizon 6 months? Is it 18 months? Is it 3 years? What we see here for this cohort is it's about 18 months. So it gives us a sense of how soon can a system start seeing benefits of this proactive intervention. As part of this intervention, every patient that had a Brave, that was identified through Brave, there were also their concerns and their expectations were reviewed by the occupational therapist. So they used the MICAW score, which is a validated quantitative tool to measure concerns and well-being. And each patient was then followed up in 3 months' time. So baseline and then 3-month follow-up. And at 3-month follow-up, the data shows a 48% reduction in patient concern scores, 22% increase in patient well-being. And then when we look over the over this time period, we see the number of admissions actually avoided compared to control group is 351. And then we can put a pound value on the health economic value of this gap. The second study is a crossover study, which was carried out over over nearly 4 years, because each patient was then followed up for 12 months. But this cohort is a cohort of care home patients, a fairly frail elderly group of individuals, about 500 patients. And this team measured falls A&E attendances and hospital discharges before, so in the 12 months prior to them using Brave to proactively identify patients. So these patients here would be referred to their team by the care home, for example, or they would be referred to through previous hospitalizations. When they started using Brave, they made a decision to only accept patients that they themselves choose for their proactive reviews. And then they measure the difference in the incidence of falls over time, and then the prevalence of A&E attendances, hospital admissions. So we can see there is an impact on hospital discharges. It's not huge, so it's about 20%. But again, these are frail elderly patients, and then many times in a care home setting, an admission is the management. But the biggest difference was in A&E attendances, and this was quite stark because it makes a huge difference for a person to be able to admit it directly onto a ward without having to wait in A&E, especially if they're elderly and frail. So this was a really interesting finding for this specific team.
Right, Ignan, thank you. I'm really sorry,
Thanks.
but we've pushed on time a little bit and we've gone over. So if you don't mind, if we move on to the next
that's fine.
presenter.
Thanks.
Thank you. It's really insightful.
Right.
And it'd be great if we can follow up and find out some more, if that's okay. Thank you.
Sure. Thanks. Bye.
Hi, Saran. Are you there?
Hello. Hi, Luke. You see me?
I can just about hear you. If you can.
Can you hear me now?
Yes,
Okay.
that's great. Yes, thank you.
Fantastic. Fantastic. So am I sharing the screen for the slides, or?
Just tell me to move on, Saran, and I'll do it for you.
Oh, fantastic. Okay, thank you. Let me just minimize mine. Yeah. Looks like a really interesting day. Sorry, I couldn't join early on. Do you want me to get started?
Yes, please, when you're ready.
Fantastic. Thank you. Hello, everyone. I'm Saran Muthaya. I'm the founder and CEO of Enrich MyCare. I'm also a specialist pediatric physiotherapist with 20 plus years of NHS experience. So firstly, thank you, Luke and the team, for giving me the opportunity to share our work. It's really exciting. The more I sort of got to understand more about the team and what we are doing today, I realized how pertinent it is, our work, to share in this forum. So thank you. My plan is to start with giving a bit of a background about what Enrich MyCare is and why do we need Enrich MyCare and what are we doing, and then really focus on a couple of case studies that might bring some light to the topic of discussion today. Yep. Right. Luke, do you want to just go back? Let me just start with, but yeah, just to give you a background understanding of what Enrich MyCare is. It's a digital platform. We see this as a one-stop platform for children with complex needs, where we bridge data, people, and importantly, clinical insights. All of that helps with early diagnosis and optimal management for these children. Thank you. And move on to the next slide, please. So let me start with giving a background information about a child called Katie, who is 7 years old, and she has cerebral palsy and autism. Katie's life is not the same. Her life is so different to her peers. She often misses her school. Sometimes she has 17 different appointments a month for her cerebral palsy, and she has to travel across different hospitals, health systems, and centers in order to access her care. The care experience is not great. Parents feel that it's a constant battle with the system due to long delays and getting lost in the system. And for her autism, she has been waiting for 18 months now. She's not received an appointment yet for the assessment. And her school is finding it extremely challenging. And the whole complexity of her presentation and the difficulty with the access in a timely manner makes it really challenging. The core issue is that care coordination across different organizations. Sadly, Katie is not alone. We have 3 million children in this country who have complex needs or additional needs. Out of that, 30% do have really complex needs. We can move on to the next slide. So let's look at Rachel. Rachel is a pediatrician who supports Katie. Rachel is one of my colleagues. Again, she has her own challenges. On the other side of the equation, she finds it extremely challenging, again, to coordinate with the 12 different professionals who sits across different agencies to be able to deliver the treatment in a timely manner for Katie. Again, she has a huge caseload, so there's a caseload pressure as well. Alongside that, it's the repetitive administrative tasks that makes it even more challenging, particularly when the data that she needs is not with her or not available at the right time, and it's all in silos, making it extremely difficult. And her biggest concern is those missed opportunities. In children, as they grow faster, it's so important to tackle things much more sooner so that the prognosis is much better than what we would hope it for. So again, the key theme here is working in silos, and there are several organizations who are supporting the needs of the child. The child being at the center is the critical point, but unfortunately, that's a huge challenge. We can move on to the next slide, please. So just to summarize these challenges at the system level, which we all can sort of relate to at some point with our experience, whatever we do. So the key is time pressure for clinicians with a huge caseload, long waiting times, but unfortunately, they don't have the right data at the right time. Lack of actionable data set makes it even more challenging. And even when you start the treatment or kickstart the diagnosis, it's the ongoing monitoring that makes it even more challenging for the likes of myself and my colleagues, where we rely on other agencies, other professionals to provide that input to us. Again, this makes it even more challenging with proactive monitoring, which we have sort of heard about the proactive nature of why we need to do this. So data fragmentation is a key problem here. Thank you. Next slide, please. So this is where Enrich MyCare comes in. It's a simple but powerful tool, particularly because it helps with connecting the dots, which is the key for us here. Whilst the school and parents do have information, as children spend a lot of their time there, that information is not available in a systematic manner for clinicians for making those decisions. So hence, the platform connects those dots. On the school and parent side, they're able to capture bespoke symptoms and presentation through bespoke diaries, which makes it much more easier because of the multimodal data that we are able to present with clinicians. And those dashboards are also really customized for different professionals, different organizations, depending on where they sit, making it much more actionable and targeted for them, as opposed to, again, bombarding with the loads of data. So that's the key. Those insights are crucial to address the challenges in a timely manner, but importantly, in a much more personalized context. And that's what we need with these complex children. Can we move on to the next slide, please? So the way we do this is we have different modules, which is much more flexible and also really powerful. So one of the modules that we have focuses on the pre-diagnostic side of things, where it helps with the referral management in an automated way. And also the AI triaging helps with fast tracking it, prioritizing the needs of children who are at the top. And also the waiting time is managed well by proactively supporting them with information. And then the diagnostic module makes it even more helpful when they come to the clinic. It's a co-production between schools, families, and they're able to sort of have a much more targeted communication with their clinicians, which helps to co-produce the diagnosis and also co-produce the management. And then comes the post-diagnostic module, which helps with ongoing support, which is a huge challenge as well. When you have huge caseloads, it's often tricky. So that's where that personalized touch points, as well as hand-holding them throughout their journey, is more sort of intelligently built into the platform. So that's a crucial aspect of the ongoing care pathway that we support. Next slide, please. So I would like to sort of pick on this case study. So we're working with the Leeds Teaching Hospital. And importantly, this is in a complex care pathway, complex epilepsy care. One of the key things here is the capturing of children with the seizures. With the complex epilepsy, there are multiple types of seizures, which makes it really challenging. And the medication response is also difficult in order to achieve the outcomes. So the information is so important. So what the app helps parents and school to do is to capture those presentations, those seizures in real time. We have a much more optimal way of capturing this in the form of questionnaires as well as diaries that helps with capturing 40 different data points. That gives rich clinical insights. And those continuous insights are much more helpful to proactively intervene rather than wait for the next appointment and recall. So we're shifting from an episodic care to continuous ongoing support without burdening the clinical team. Again, that's so much more important. In this particular case, it's about early pattern recognition, or all of that helps with better decision making with medication, as opposed to trialing for months and then it takes ages to get the right optimal dosage or the cocktail of drugs. We're able to make that impact and shorten that sort of pathway, which makes it easier. Again, going back to the theme of the day, it's here families acting as active partners in neighborhood health. Next one, please. So the next case which I want to share with you is an example of what we do in Derbyshire within the autism and ADHD pathway. Here, clearly, schools are acting as active partners within this neighborhood health and proactively sort of initiating that care pathway. So as we all know, children spend a lot of time in schools, so they have a lot of information, rich data that can be really useful for clinicians to make those decisions. So hence, here in this case, schools are able to initiate that communication through the platform. They're able to have those screening questionnaires and support tools to empower them to how to support and what to do, but also initiate an automated referral through our platform, which then helps the clinicians to alert the severity of the child, and that can be prioritized with the triaging, but also there is this ongoing capturing of behavior, communication, and also sensory needs. All of that once again helps to fast track their appointment, because the triaging and prioritization helps with reducing the clinician having to spend that admin time, which means that we were able to sort of cut down the waiting time by 1/3. Often, as we know, the waiting times are really long across the country. It ranges between 18 months to 4 years or so. Again, this is a huge piece of work that we have done, which we're really excited. But the key thing is, again, it's the schools and parents actively participating and initiating, which is crucial here. They don't have to duplicate the information again and again, both schools by doing lots of questionnaires or parents having to repeat that again and again. So also what we have found is the quality of referrals to the service is much better now, because the low-level needs are all being met and handled by the school because of that information in a personalized manner provided to them. They feel empowered in this context. Thank you, Luke. Next slide. So what we feel is we don't have a data problem, though the data is inadequate at times and the quality of it is questionable depending on where and who provides it, but the data is available. That's where we are able to support with the capturing rich data sets which are actionable, which is crucial. But importantly, the huge challenge is the connection problem, which we all know, and that's where this golden wheel of connection is going to be really helpful to ensure that the needs of the child are met by having them at the center of the ecosystem, rather than something is done to them without their active participation. That's where we feel our platform becomes the digital bridge for complex care. Next slide, please. So in terms of the impact in relation to the theme of the day is we see digital platform as a connective tissue within this fabric, within this health system. Particularly children with complex needs benefit most through the neighborhood approaches, as you've seen in those examples. And the proactive case finding is crucial, and also it would be successful when it's embedded really well within the care pathway. I think that's the crucial part of it, and it has to be family and child centered in our context, and it has to be clinically led. Only then the outcomes are met in a meaningful way. For us, at least, having sort of gone through this exercise, we feel that it's not a new service. The neighborhood health as a concept is a new way of seeing things, but it's not a new service in itself. Thank you. Next slide, please. So it's not just a new service, it's also a new way of seeing patients, where the ownership, the empowerment, and the patients and families are at the center of this ecosystem is a crucial point. And hence, with the right partnership, we can really change the lives of every child and family. Thank you for the time. Thank you, Luke. Thank you, sir.
We've just got a couple of quick questions in the chat.
Please.
One of them being, what control do parents have about communication of parents providing information between agencies? And then conversely, agency control of information to parents as well.
Fantastic. That's a great question. Thank you for the question, Michael. The easy way to say this is it's like a tap. So the person who is adding information onto the platform, who's capturing it, has the control in terms of with whom they want to share that information. Of course, when it's initiated as part of a pathway, there is that direction from the service and the initiation of this is what is expected of each of the stakeholders, i.e. school, i.e. families, and what the clinicians have to do. And often, one of the things that I've heard families complain is, when a communication happens about my child between different clinicians or agencies, I really don't know. I want to be part of that conversation. Hence, the platform helps with opening that conversation out. Again, it's also driven by clinical need. So the clinical teams can sort of share whatever they want to share through the platform, which is then made available for schools and families. So we can really have those role-based access, and the organizational data sits with that, but the data that we capture here is the data that's currently not available in electronic health records. So it adds the richness and makes decision-making easier. I hope I've answered your question.
Thank you. I know that you have to run to another meeting, Saran. So if you can, when you get a minute, there is a few other questions in the chat. So if you do get a moment to kind of answer them when you get time.
Will do. Absolutely will do.
Brilliant. Thanks a lot.
Thank you for the opportunity, and have a great day, everyone. Thank you. Bye.
Next up, we've got Uma from Abtrace. Are you there, Uma?
Here.
Hi there. I believe you're going to share your slides, so I'll just stop sharing
that. I will share my screen. Right. Okay. Hope you can see the screen and you can hear me okay. And please stop me if you can't. So my name is Umar. I'm a doctor by background. I'm the CEO of Abtrace, NHS doctor, CEO of Abtrace. got that right. I'm going to tell you a little bit about Abtrace. So we automate proactive monitoring, and what I'm going to do is show you a live demo, because I think that's the best way of understanding what the product does. Just before I do, just to give you a sense of the company, if you have not heard of us, hopefully you have. We are currently working and processing the entire health record of 6 million patients in the UK today. We're live in every single ICS, or 42 now. We're fully integrated with EMIS and System 1, and in the process of integrating with Medicus. So we cover pretty much any practice in England, and we have practices all over the country, and we're growing very, very quickly, so to at least doubling our footprint every year. And what we do is we look after proactive care, and our model is that GPs are overwhelmed. They have plenty to do. So asking them to do more and more is quite hard. There's a lot of different incentives. There's a lot of different diseases, and every disease, if you're diabetic, there are multiple guidances that need to apply to you. So even for a single condition, there are multiple different ways of managing that. So unless you automate that work away, giving staff more guidance, more guidelines, more pathways is going to be, you end up focusing on something new and then something else drops off the other side. So that's our vision, and what we've built is something that completely automates that work. And so I'm going to just dive in and hopefully give you a clear idea. So for those of you who work in primary care and have tried to run searches or done research in primary care, you'll know that if you use existing electronic health records and you try and run a search, it will literally take you hours, if not a day, to get the result, and it will slow everybody's computer down. And so if you want to know how many people need a smear today or how many people need a blood test today, you can't find out right now. You literally have to wait hours to get that answer. With Abtrace, we integrate into these systems. We run every single search across every single data point, every drug, every disease, every condition, blood test result. And in 1 second, if I put in who needs a cervical smear today, it in 1 second gives me that result. It is literally as quick as that. And that's because of the technological approach and the deep integration we have. And so I'm not interested in the people that are complete. I'm interested in the people that are still overdue. And I can find those people. I might say, well, I don't want to include people on the palliative care register. I don't want to include people who are in the care home, because I'm not going to be able to get them to come in, and it works as fast as that. And again, for those of you who use primary care systems, you'll realize how much better that is. And if you don't, trust me, it's a lot better. So the next step is bringing these people in, and I won't show you a full demo, but you can, in a couple of clicks, send these people messages, send them appointment booking links, etc. But the unique thing that Abtrace does is that you can automate that process entirely. So I can say, well, I don't want to come back every month or every week and try and bring these people in. I'm going to just say, from now on, anybody who meets these criteria, I'd like to bring in 35 of those people in once a week, every week, because that's the capacity I have. And I want to start with the most overdue people. And so what this system is going to do is it's going to act as a really effective, capable administrator or healthcare assistant who will reevaluate your population every day across all the latest guidelines and decide who needs to be brought in. That includes the person who joined your practice last week, or the person who's just been diagnosed with a new condition that puts them in the need for having this test. And it will reevaluate, bring the right people in, get them booked into the right clinic. And you can say, well, I want to send them 3 appointment in reminders. I want to send them 7 days apart. I don't want to send, if they book in, then please don't try and message them again. We don't want to spam people, and so on. So the system will then work from you. You can specify the appointment slots that you want to make available and get these people booked in at the right time with the right place. So this is about completely automating all of your recalls, no matter how complex your patient population is and how complex the different guidelines are. Once you set this up, you never need to pay attention again. So from practice perspective, this will automate the work of 2 or 3 full-time equivalent people on day one. And when that patient comes in, so we brought this patient in because they were eligible for a smear and so on, but bear in mind that these patients are eligible for a lot of different things. So this view is looking at every single patient across all conditions at the same time. This is your total population. And if I bring this patient in, I have a view like this that tells me everything else they're overdue. So this is about making every contact count and making sure that at your fingertips, all your staff receptionists, nurses, healthcare assistant have the ability to do everything that's required. So this patient needs blood pressure. Actually, there's multiple reasons they might need a blood pressure. And Abtrace is unique to be able to cover all of the conditions, all of the rule sets, not just QOF, because we don't want to sort them out for QOF and then miss out CQC requirements and other monitoring. And so this is very much a holistic platform. It's not looking at diabetes or cholesterol or vaccinations. It's covering every single thing in a single view. And so you can use it to manage all the workflows, but then when the patient comes in, you can use it to sort out everything that that particular patient needs, whatever the reason, whatever the indication. And so this product, as I said, is being used at the moment. We're covering 500 practices plus in the UK, and about 50 more sign up every month. And we want to give all of these practices control. So we want them to be able to choose. So what you get with Abtrace is this ability, this sort of command center, which says, what do I as a practice want to do? So this is a relatively rare drug. I need to monitor liver function tests. As a doctor, I will turn this on, and from now on, all my patients who are on that drug will automatically have that suggested and will be brought in at the right time at the right place. So this is really about setting your strategy once, and then the system will enact the strategy for you, rather than having to cascade that down to different members of staff. And people leave, it's hard to retain staff. The guidelines keep changing. Today, if a guideline changes, you turn it on here. From tomorrow morning, every single member of your staff will effectively be following that guideline and best practice without necessarily needing to worry about the details. Bunch of other features here, which I won't have time to go into, but I will point out the patient part. So one thing is about bringing the right people in to the right slot, to the right member of staff, and then making sure that member of staff does all the blood tests. But also, we know that in primary care, we overwhelm patients with demands. We send them 20 messages. We tell them to come in for their blood test, and then we ask them questionnaires. What Abtrace does instead is it gives them a single portal. So every time a patient is contacted, either via their NHS app or text or email, they will end up on a portal like this. And so they will be able to see what they need. This is my personalized view of what my healthcare needs will be for the rest of the year.